Endotracheal intubation. Introduction. Endotracheal intubation involves the oral or nasal insertion of a flexible tube through the larynx into the trachea for the purposes of controlling the airway and mechanically ventilating the patient. Performed by a practitioner, anesthetist, respiratory therapist, or nurse educated in the procedure. Advantages of the procedure are that it establishes and maintains a patent airway, protects against aspiration by sealing off the trachea from the digestive tract, permits removal of tracheobronchial secretions in patients who can't cough effectively, and provides a route for mechanical ventilation. Disadvantages are that it bypasses normal respiratory defenses against infection, reduces cough effectiveness, and prevents verbal communication. Indications. Inability to oxygenate patient. SpO2 less than 90%, PaO2 less than 55. Inability to ventilate patient. Rising PaCO2, respiratory acidosis, mental status change or other symptoms. Patient unable to protect the airway. GCS-8. General anesthesia. Cardiac arrest-CPR. Contraindication. Massive maxillofacial trauma, relative. Fractured larynx. Suspected cervical spine injury, relative. Equipment. Patient positioning equipment. Bed or procedure table can be raised and lowered. Pillows or blankets can be rolled and placed under patient for optimal positioning. Monitoring equipment. Pulse oximeter. Blood pressure gauge. Cardiac monitor. Continued. Oxygenation equipment. Oxygen source and tubing. Face mask. Anesthesia bag or self-inflating ambu bag. Suction catheter with Yankauer tip. Premedication and induction equipment. Intravenous access. Premedication agents. Induction agents. Paralytic agents. Continued. Intubation equipment. Laryngoscope handle and blades, different sizes and shapes. Endotracheal tube, different sizes. Tube tie, to securing tube in place. Equipment for verifying tube position after placement. Stethoscope. Carbon dioxide detector or end-tidal CO2 monitor. Esophageal syringe or bulb syringe. Chest X-ray to verify position is also required. Intubation procedure. Position patient. Bed at comfortable height for laryngoscopist. Patient aligned without lateral deviation of head or neck. Shoulders and or neck supported with rolls or pillows to allow positioning of head. Neck flexed approximate 15 degrees on chest. Head hyperextended on neck to maximum comfortable degree. Pre-oxygenate patient. 5 minutes on 100% oxygen with mask. Laryngoscopy technique. Hold laryngoscope in left hand and endotracheal tube in right hand. Open the patient's mouth with a right-handed scissor technique. Insert the laryngoscope blade on the right side of the mouth and use it to sweep the tongue to the left. Continued. Advance the blade until landmarks are recognized, usually the tip of the epiglottis or the arytenoid cartilages. Lift, not lever, the laryngoscope in the direction of the handle to lift the tongue and posterior pharyngeal structures out of the line of sight, bringing the glottis into view. Continued. When the vocal cords or the arytenoid cartilages are clearly seen, advance the tube down the right side of the mouth, keeping the vocal cords in view until the last possible moment, then advance the tube through the vocal cords. Insert the tube to 23 centimeters, at incisors, in men and 21 centimeters in women, then inflate the cuff. Continued. Attach bag ventilator to tube and verify tube position immediately. Listen for breath sounds. Attach CO2 detector to tube or use end-tidal CO2 monitor to verify return of carbon dioxide with each breath. Secure tube in position and request chest X-ray to confirm position. Complication. Trauma from laryngoscope. Teeth avoidable with proper laryngoscopy technique. Soft tissues, bleeding, avoidable with proper laryngoscopy technique. Edema, due to repeated attempts at laryngoscopy. Optimize something with each new attempt, not simply repeat procedure without addressing a possible reason for failure. Continued. Improper tube positioning, esophageal intubation, right mainstem bronchus. Aspiration. Tube obstruction or kinking. Documentation. Record the date and time of intubation, its indication, and whether it was successful. Document the type and size of ET tube, external length measurement from the patient's lip.